Welcome, welcome. Got folks streaming in, and if you're can open up your chat, would love to hear where people are broadcasting from today. And welcome to This Clinical Life, proudly presented by Practicing Excellence. In this podcast, we talk about the transformational impact of human development and developing the skills of our care teams to create incredible change in healthcare, a powerful yet often overlooked catalyst for positive change. So I am absolutely thrilled today to, welcome. We've got Dallas, we've got Tucson, we got Oregon, we got folks from all over the place. And today we have Beth Lown, who is, I've been tracking professionally for some time now. I'm not sure she knows that. But she's currently the Chief Medical Officer for the Schwartz Center for Compassionate Care, has a long storied history at the local, national, international level as an advocate, voice, ambassador, teacher, policy creator, educator on advancing compassion in healthcare. So Beth, welcome to This Clinical Life.
Thank you for having me. I'm
Yeah.
really looking forward to this. This will be fun.
So I want to begin. I always like to find out what the initial story is that sort of, first of all, what got you into healthcare and how did you pivot from I'm an internist to I'm now sort of a national advocate for raising compassion in healthcare? Tell me a little bit about that thumbnail journey.
Well, okay. So I started out in the arts. I was going through college at the height of the feminist era, the civil rights movement, the war in Vietnam, and I became an activist as a result of the convergence of all of those incredible social forces for change, and decided I really needed to be of service to others. And so I decided to go to medical school, in part at the urging and encouragement of a very well-known physician who eventually became my father-in-law, Dr. Bernard Long, who used to take me on rounds with him at the Brigham. This was a long time ago, but he actually started the intensive care unit there. He was a pioneer in intensive care, and he started taking me on his Saturday morning rounds. He'd pick me up, we'd go drive in, this little young girl at the back of this entourage watching him interact with patients. And I will never forget watching him and how he spoke with patients and sat next to them, sometimes held their hand if that was the right thing to do. I remember especially watching him caring for a woman who just had terrible refractory ventricular arrhythmias, somehow had survived to make it into his service. And no one could figure out what was wrong, what was triggering this. And he managed to hear and elicit the story of her watching her parents be marched into a concentration camp and watch them essentially perish. And whenever she had memories of this, she would develop VTPF. Quite an incredible story, but afterwards is what really spoke to me, because he turned around and you could see tears were welling up in his eyes, and he was so moved, and she was so connected with him in that moment that I said to myself, okay, this is how you provide high quality, excellent, compassionate care, and I want to do that. And that's sort of what got me off on this whole journey.
Wow. Well, we could even contend that we get the diagnosis and the treatment modality right with the clinical intervention based upon evidence to advance the outcome for the patient. If we do not bring the signals and the warmth and the behaviors of compassion, patients may never see that as exceptional care.
I think that's true. I mean, it's all about connection, isn't it? If you don't feel connected with your care team and you don't trust them, then you may not adhere to what they're saying. You may not even hear what they're saying. So it's a very, very reciprocal process of listening, understanding, building trust, and then sharing the information with each other that each side of the relationship needs to co-create the best possible care and health outcomes. It has to be a reciprocal, integrated process.
And we're really diligent about applying evidence to a clinical intervention to yield an outcome, but and to reduce clinical variation on that front and how we manage disease. But the variance around our expression and delivery of compassion is high, meaning there are times when it's not present at all. There are
Mhm.
times when it's present in abundance and everything in between. Um, I want to back up a little bit and ask a little bit about how you see the state of healthcare, the healthcare workforce right now. Uh,
Mm.
all of us are deeply entrenched in how do we advance the conditions that healthcare workers work in to improve the retention and the engagement of our clinical talent and the well-being and vitality and contentment of the clinical workforce. Um, how are we doing from your perspective, sort of as a compassion ambassador? What are you seeing in terms of our industry, in terms of the trajectory of the well-being of the care teams right now?
I think it's a really sort of a mixed story right now. I mean, it's amazing to me how miraculous healthcare and medicine is and can be. The miracle of modern medicine is astounding. You only have to look at, the speed with which the vaccines were developed and, well, could have been implemented a little faster, but, we have the capability. I think what's happening is we don't have the correct infrastructure, access to healthcare, the correct kinds of, in my opinion, processes, payment methodologies, the infrastructure, the overall societal impetus to make healthcare a human right, to provide access to everybody, I think is lagging. And right now, especially, there's, hospitals in particular are strapped. Well, not most, but about 40% of hospitals are operating at a loss. And that's primarily due to labor services and fees and the increasing, rise of inflation and so forth. And so what's happening between this and sort of the consolidation of healthcare is that in the face of persistent staffing shortages, the healthcare team is increasingly stressed and pressed. Patients are sicker, they're staying for longer, there's an increase in workplace violence. There are a lot of things on the ground that are happening that are contributing to this unbelievable sense of pressure, malaise, and just unhappiness that we can't provide the kind of care that we really want to provide. It's no surprise that, the rates of burnout are still high, 50, 60%. The rates also of moral distress are high, 40%. 41% of nurses in the ICU are reporting symptoms of PTSD. I mean, these are this is going the wrong way. I think for me too, one of the really distressing indicators are the percentage of students in healthcare, residents and fellows who are either increasing the use of drugs and other kinds of, alcohol to cope, but also actively considering self-harm. And to me, that is just an enormous tragedy. We know that the rates of suicide are already twice as high as they are in the other professions, particularly amongst women, women physicians, nurses, women nurses. So we have a significant dilemma on our hands. The question is what to do about it. And I think that we have to take a really holistic, multifaceted approach. We have to be thinking simultaneously about how do we support patients and families as whole people within their communities, within the places where they work, social determinants of health. How do we support their health, offer healing, while also supporting the healthcare team and providing the kinds of infrastructure, policies, processes, support, and measuring impact on healthcare workers so that we know that whatever we're doing is actually improving their health and not making it worse. How do we hold those two simultaneously, and what do we do about that? I think that we have to be thinking on so many different levels, at the level of the care team, the level of patients and families, but especially at the level of leadership and the culture of healthcare organizations. And that is the place, in my opinion, where the most work is needed, because I think it's going to have the greatest impact.
It's really interesting reflecting on what could be the role of compassion to be able to advance the experience of care team members, which you clearly articulated. And we have a real workforce instability and workforce shortage right now. I can tell
Mhm.
you what's interesting about the physician workforce is that there's a survey done recently that nearly 50% of recent graduates from medical school don't have the intention of seeing patients,
Mm,
meaning the conditions of providing care in primary specialty and surgical care are such that people are looking to use their medical training to get into biotech,
mhm,
innovations,
mhm.
their world. And so if we don't fix the conditions of what is it like to provide care in our industry, we're going to have a radical shortage of healthcare uh, talent, physicians, nurses, and support staff.
Yeah.
So what's interesting, and bringing this back to compassion, and again, compassion, and I think I copied this from you, and it's sort of well circulated in terms of what compassion is, but really four steps: an awareness. Number one, an awareness of suffering. Number two, uh, feeling emotionally moved by that suffering. That there's something that moves you about witnessing that suffering. Number three, wishing there to be relief of the suffering. And number four, a readiness for action.
Mhm.
So if that word compassion, and we think about how do we apply the notion of compassion to two key areas: the delivery of care for patients and the support of care teams in our healthcare environment.
Mhm.
So I want you to speak a little bit. We're going to talk about taking care of the care team now. And you spoke about healthcare leadership. How important is compassion for healthcare leaders as a countermeasure to the experience of our care teams and well-being and burnout that we're seeing now?
I think that without it, we're not going to address those shortages. What is it that moves people to come, to care, to, be of service? What is it that calls people to the health professions? It's the desire to heal, to nurture, sometimes to do research and do science, but very, very often is the desire to be a healing presence in the life of people who are suffering. So if we cannot do that, how can we possibly expect the healthcare team to survive? How can we expect healthcare to survive? You know, to me, it's really it's the foundation of just about everything. It's the thing that draws us. It's the thing that calls us. Compassion is what drives people to healthcare. And it's what rewards us. We all know that when you're experiencing compassion, the reward centers in the brain are activated, right? So without that continuous sort of, yes, I am offering myself as a healing presence and I am receiving the suffering of someone, not absorbing it, but I am receiving it in a way that will lift both of us in the act of offering this kind of connected, relationship-centered, loving care. I use the word love. People don't like it, they think it's crossing borders. No, medicine is a lot about love. Healthcare is a lot about love, boundary love, but love.
Right.
And without it, we can't survive. That's what the Dalai
So,
Lama said.
having compassion as a leader for those that we lead
Mhm.
again, it's a recognition of suffering, being moved by the suffering, a hope to get that suffering to go away, and taking action to relieve that suffering. Again, that's transcendent for patients going through an illness and care teams going through delivering care.
Mhm.
For those healthcare leaders that are on right now, and there's a lot of them, what would you say is the sort of the persona of the compassionate leader, and how they can leverage compassion for their care teams to advance the well-being of their teams.
So there's one little piece in the 5 points or whatever it was that you mentioned, Steve, that I think is missing one important piece, and that's the element of assessment. I think without understanding what people really want, whether it's a patient and a family or a community, or if it's members of the care team, you're very likely to get it wrong. So assessment is a very, very key and critical piece of the whole process, the whole ever circling wheel of compassion. I think, the persona of a leader, clearly they have to protect the financial stability of their organization. That's basically what, they're hired to do that. But caring about the staff, about all the entire workforce, not just professionals, but everybody, uh, can be demonstrated by being a visible presence. Being actually doing leadership rounds, for example, is a really important way of demonstrating that you actually care, that you care enough to stop and to listen. But that's not always enough because, as we know from one of the projects, our Healing Healthcare Initiative project, we have learned from one of our pilot sites that that's not sufficient because many people are not going to stand and speak to a leader, especially if they're not in a senior leadership position themselves. So then you need multiple ways of receiving bidirectional feedback as a leader. And you have to analyze them. You have to really group them, prioritize them, understand what the overarching themes are, what the exact needs are, and they're going to be different from each profession, maybe each different unit or team. And then you have to prioritize and then decide what you're going to do. And the most important piece is let people know you heard what they said, and this is what you're doing about it. So that they can actually see this kind of closed loop communication and know that their concerns are not going into the wastebasket, they're actually being heard. So that's, just one element of demonstrating compassion as a leader. There's so many more things that one can do, but I want to just describe sort of an overarching framework for compassionate healthcare culture, if you would permit me to do that, because I think this is not just about role modeling, and it's not just about providing individual support. If we don't approach the organizational culture and the systemic issues within the culture, it's going to be hard to really move the needle on clinician engagement, professional fulfillment, burnout, and all the rest. So we actually, through a lot of work in a national advisory, group, came up with these key principles, we're calling them, 6 key principles that we think provide the foundation for a compassionate organizational culture. And they include psychological and physical safety, and it's up to the leadership to really figure out how to secure that, create a safe and trusted environment. Inclusion, voice, and choice involving health workers and actually co-creating decisions, trying to find solutions. We have an incredibly brilliant, healthcare workforce that when they're in the front lines on the, in the trenches, so to speak, I don't like these military analogies, but they're the ones who know how to solve problems, they're in it. Securing and addressing all forms of structural discrimination and racism, diversity and equity, fostering team cohesiveness and collaboration, mutual respect, shared purpose, collaborative learning, making sure that you're building trust. And the way to do that as a leader is by demonstrating that you're trustworthy. Just as I said, you're hearing the concerns, you're going to act on them, you're going to follow up, you're going to be ensuring that these things are actually addressed one way or another, or if not now, let people know when they could be. So building trust and trustworthiness, and all of that really contributes to mental health and well-being, which is our 6th key principle. We kept it separate because we also wanted to be able to stress the need to reduce stigma, the need to make it okay to say I'm not okay, and to address some of the systemic barriers to getting help. So that is our framework for compassionate organizational culture. And the idea is to really involve health workers to understand, prioritize one of these or 2 of these, and help use the workforce to help you understand what do they need to be able to implement this. What kinds of policies, processes, and practices can be implemented that would address the specific needs, especially the people who are suffering the most, which requires measurement. And, that is the other thing I will just say, that, without asking questions and measuring results, you're not going to be able to improve. So, I think that like I said, I think it's a matter of valuing compassion and asserting that commitment, living that commitment, making that the way you walk through the world, modeling it, role modeling it, being a visible presence, being accountable, following through on what you hear, and then helping by working with the healthcare workforce to actually implement key processes, policies, whatever it takes to implement some of these key principles or, over a period of time. I think that is the way to move the needle on compassion.
Well, I think that if we could wave a wand and have leaders lead with compassion, with all the elements of keeping their team safe, psychologically, physically, tapping their voice and enable them to bring forward solutions, full empowerment of their teams, to foster a sense of uh, fairness and diminishing inequalities that are still a large part of our culture. A sense of shared purpose and why are we here and what does it mean to be us? And all of these things are, if we as leaders can deliver the behaviors and cues and actions and mindsets fueled by we care about the people that are working here, and we will take these actions to help and support these teams. Our thesis, my thesis, and I think there's pretty good literature behind it, is how an organization is led has profound impact on what it's like to work there. And I would also contend that the variance around how leaders are showing up, particularly at the manager level, is the variance, sometimes we refer to as leader cohesion, is very, very high, meaning some are compassionate, some are people pleasers, some are growth mindset, some are fixed mindset, some have candor, some micromanage, some enable, some tap ideas, there's just wild variance in how it is that we're leading. But I think as you articulated, there are principles that leaders can engage in and actions that they can take that are proven to advance the well-being of their team, but we haven't yet created consistency in leadership in healthcare, in my opinion. I don't know what you've seen in terms of the consistency of leadership powered by compassion to advance the well-being of teams across our industry. How would you characterize that consistency?
Oh, it's incredibly variable, as you said, I don't even know that we have any data on that. What we do know, though, is that leaders who support those who work for them, boost their workforce well-being. They boost the engagement of those who are, working directly with them. That's true for supervisors and managers, not just leaders.
Right.
I know Tate Shanafelt's work has shown some of that, and actually, the supervisor and manager support is well demonstrated to boost workforce engagement. There's a lot of data around that. There's a lot of questions in the chat I'm noticing too about
I know. I'm getting
measurement.
tons of things coming in here,
Yeah,
and some commentary on. Uh, so we're gonna try to get to some of those at the end here.
yeah,
Uh, and feel free to drop in commentary. Feel free to drop in questions, and we'll try to address those
yeah.
as we proceed. One of the other things I know that compassionate leaders and all the behaviors and mindsets and actions that are associated with compassionate leaders could be a powerful intervention to help advance the well-being of a very distressed workforce right now.
Mhm.
And including listening and responding to our teams, what is most important to them, and taking action to reduce burden, in addition to all the other things that you had mentioned. I want to talk a little bit about compassion within healthcare teams
Mhm.
and compassion for each other to your colleague at your shoulder, at your elbow that you work with.
Mhm.
Talk a little bit about leadership. Compassion is important, but I want to toggle down to the team, the compassion of the team for each other. Talk a little bit about what you're seeing there, and what are some of the best organizations doing in terms of building teams that have compassion for each other and collectively for the patients that they take care of.
I think there's I'll tell you what I think is the secret sauce: social support. So there is a ton of data and research that shows human connection, deep relationships, and social support are the absolute keys to good health, happiness, and longevity. It's, something that's come out of that Harvard study of adult development. It's the longest study on adult joy and happiness in life. But the surprising thing was that social support actually prolonged life. And there's research by Julia Holt-Lunstad as well,
Mhm.
showing that deep social support, integrated social support and social networks actually prolong life and have a greater impact on mortality than lots of the usual risk factors that we know so much about, smoking cessation and all of that. That social support trumps all of those things with regard to extending life. So that is important for teams as well. I think that the need for peer support is really important and is essential. I mean, when people are distressed, they want to turn to someone who has walked their walk, someone who really knows what it's like to be in their shoes. They don't want to seek outside, counseling care necessarily, partly because of the stigma involved and the vulnerability that's necessary to do that, but also because often it just doesn't meet their needs. So really well-structured peer support programs and there are tons of best practice examples of those. Many of the sites that we've worked with have implemented variations on that. We actually, at the Schwartz Center, worked with the National Center for PTSD during the pandemic to start our own stress first aid program and offer it to our membership. And that's based on, these are consensus-based, internationally based standards of what you need to do in the immediate and sort of midterm evolution of a crisis, an emergency, or a disaster. What is it that people need to feel and to experience in order to survive? And all of that got baked into our stress first aid, course. But the basic thing is that it requires connection, collaboration. Again, being able to notice that someone is distressed, understanding how to pick up those cues, approaching to assess, are you open to me reaching out to you and responding to you? Being able to respond appropriately. Just like in primary care, you can't just come up with a solution and, I'm an old-time primary care doc, but you can't just come up with a solution. You have to understand the context and the circumstances of the person who's suffering in order to really come up with the best possible way to address it. And it's the same thing with peer support as well. So that's why I think, it's not a huge jump. We know these skills. We do these every single day. The question is, are we setting up the circumstances and giving some of the training, actually, the skills-based training, so that you can effectively reach out to your teammates and to sort of provide the same kind of care and compassion to those teammates who might be suffering? It's different from, being in the presence of patients. There are boundaries we have to respect. But the skills, we have those skills. We just need to buff them up, get a little extra training in them, and then apply them.
Well, it's interesting as you say that, we think about and talk about our initial topic, which was how do we deliver compassionate leadership to advance the well-being of the teams that we lead. And I would contend that my best and worst of life experiences as a physician were directly related to how I was interfacing with my leader and the signals and the cues that I was giving from my leader and the compassion for the team itself. And really interesting, the formal peer support, where there's a formal mechanism to
Mhm.
identify and outreach with a like peer to help and support. What I'm also interested in is sort of a wider aperture of peer support, meaning sort of a peer support culture that where being a member of a care team, we just simply look out for each other.
Yeah,
We know what the yellow flashing lights are.
right.
We know each other and what matters to each other.
Mhm.
We know each other's names and their
Mhm.
roles and their hopes and dreams and ambitions. And as a part of being a team, we just say, we're going to look out for each other. Meaning there's going to be moments where some of us are going to be tripping and falling personally or professionally.
Mhm.
And being a part of this team, we're going to lift each other up. And, sort of an informal peer support culture. And what being in a place like that where people say, there are people here that care about me, that will lift me up, and I will lift them up.
Mhm. Oh, that is
That's
so,
right.
that's
So
what keeps people there.
right. Our durability in this really difficult challenge right now is about people looking out for each other. And that is compassion, right?
Yeah.
It's compassion within a team and hopefully across teams to say, here in this culture, not only do we lead with compassion, but we have compassion for one another because this
Mhm.
is really hard right now.
Yes,
Um,
yes, yes. That all builds a culture of compassion. I totally agree with
yes,
you, Steve. Absolutely. And to do it proactively. So the idea is to move from learning the skills, embedding them in the way you sort of orient yourself to your work so that you can activate and use the skills that you have to provide that kind of support, but also then making it sort of, okay, this is how we do things here. This is our
here we
culture
are.
here.
Right. It's what it means to be us.
Yeah, exactly right.
And we,
And
right, right. Go ahead.
I was just thinking, there's nothing, and when I think about my own experiences, the thing that glues you to others and to your work is the team. If you ask people, what is it that keeps me here? They'll often say, it's my team, it's the people I work with, it's my colleagues. That I've heard that so many, many, many times. I can't even tell you.
Gosh, yes.
Yeah.
It was interesting. I remember when I was in my family medicine days, I had a patient of mine who was in the special forces and he was a Navy SEAL. And, we became, I always like to find the story of the patients that we treat because that's where the beauty of medicine resides. So, I asked him, I said, what is it that prompts you to do what you do? Because special forces do all sorts of things, most of which we don't even know about, that we can't imagine, incurring risk and going into dangerous areas and doing things that are barely humanly possible. And I said, what is it that prompts you to be willing to do that? Is it country? Is it duty? Is it your training? What is it? And he said to me unequivocally, without hesitation, it's the soldier at my elbow.
Yes, 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 yes.
And to be able to build that kind of culture where we just look out for each other.
Mhm.
It doesn't fix all the stuff that is difficult in American healthcare, but man, it seems like we've got access to that one. We can build
Yeah.
a culture where people look out for each other. Um, so
Can I mention one more thing? There is also, just to drive home this other point about how do you create a compassionate organizational culture. There's a health services researcher, actually Laura McClellan and Tim Vogus did this, showing that compassionate organizational practices improve patient satisfaction, not just staff engagement, but patient satisfaction using HCAHPS as a measure. And those practices include things like peer support, providing a safe, reflective space where people can come together and talk about their experiences and the impact of providing care, like Schwartz round. Sorry, I'm just going to say it. I know, conflict of interest, but it's true. There's a ton of data around the impact of offering safe space to process what is happening to us, whether it's done one-on-one or in community. That's what is needed. We need a chance to step back, some protected safe space for courageous conversations about what it's like to be us, to be taking care of sometimes desperately ill or traumatized patients. We need that time and space to pause, to reflect together, to listen, to learn, to offer, and to receive support. And that too builds a deep sense of community as this is the foundation of how we do our work. It's very, very important. And there is plentiful evidence to support its efficacy and its impact.
well, there's so many questions that are in the chat. This is going to be a 4-hour webinar. This is going to be a Joe Rogan. We're gonna finish up in the next 10 or 15 minutes. But
Okay.
there's such good questions that are coming up. So some of the questions that came up on Paul had asked about, this is more difficult in an open medical staff model, and which is still a predominant structure in terms of physicians anyway, and how they interface with the hospital. Uh, and you're right. I think that when we have an open medical staff model with lots of autonomy and independence in terms of how people are showing up, uh, I still think there's an incredible opportunity during credentialing, during onboarding, building a human development strategy to advance the skills of looking out for each other, to lead with compassion and have compassion for patients. I think human development as a change catalyst
Mhm.
is largely untapped in terms of I know you spent much of your life training and developing people to advance compassion as leaders, as teammates, and for patients.
Mhm.
But still, the application of a human development strategy within a hospital environment can help and support and signal, this is what it means to be us, and here are the skills and behaviors that reflect our identity. So what I would like to ask you, as we talked about compassion for team members and compassion as leaders, let's take compassion down between care team member and patient. Uh,
Mhm.
and and what does that look like? And how do we do that when care team members are so administratively
Yeah.
overworked, overwhelmed, disengaged, frustrated, and already burned out? What is the role of the delivery of compassion for patients, which we know is so incredibly important? How do we do that in the context of the disengagement and burnout of our current healthcare teams?
There are three things I want to say about that. First is we have to address the administrative burden and get the clinicians who are using the electronic health record to fix it, to gather together to decide what are the pain points, how can we minimize them, what's acceptable, what's regulatory and can't be minimized. But if that's the case, then how do we advocate for less uh, less metrics and requirements that to be checked. I mean, there's nothing worse than going in to see a doctor who's going through this checklist, and by the time you get to the checklist, the visit is over and you haven't even got to why you came there in the first place. We've got to get rid of that stuff, we've got to figure out some systems so that either it's offloaded to other kinds of processes, or people, and just diminish, all of that burden. The piece in the New England Journal that called it "Get Rid of Stupid Stuff." So work with colleagues to figure out what can be, diminished, and how do you get people to help you manage your inbox and so forth. So that's one thing, technology management. The other thing I would say is compassion is expressed in seconds. Sometimes all it is an intense focus. When you walk into somebody's room, you make it a point to pause, to set aside all of the noise in your brain and the people and the tasks, so that when you walk through that door or into that room, your focus is solely on that person. And that person will feel that and experience it. And that really expands a sense that when you're in the room, they are the only thing that matters to you. That is felt as such a gift to someone who's sick or vulnerable. And it feels like time stands still in that. People perceive that as taking a lot more time than it actually takes in reality. That need to be completely present, even just for a few moments. And sometimes it's just a kind touch. It's a word, it's direct eye contact. It can be so many little things, and it does not take a lot of time. However, if we're talking about primary care and real compassion, again, if you're trying to really make informed, shared decisions, you have to have some way to get the time to explain everything that people need to know, and for you to understand what they perceive, what their concerns and questions are, and what their circumstances are, what they're actually going to be able to do, given whatever socioeconomic determinants they're trying to deal with. That can take some time, and that's just healthcare. What else is there to do if we're not doing that? We have to do that, and there has to be time allotted to do that. So, those are the three key points I wanted to make, that, we got to fix the technology. It can happen in moments, but we also have to figure out ways that we have the time. Why are we being asked to telescope everything into an amount of time that's not suitable for the task we're being asked to do? It's not good for us. It's not good for patients. And how can we address that? What's it going to take to really address that, so that the way we structure appointments and schedule, the way we're reimbursed for these things, so that it represents patient family-centered care and relationship-centered care. So it takes care of us. Well, it also takes care of patient families. That's what I would say has to happen. And I know it's, maybe it's going to be a while in coming, but we can control how we respond.
And I think that, thank you for sharing those things. I think the one thing that I would add, two things I would add. One is the development of skills that reflect compassion.
Yes.
I think that those, just like, how we, cannulate an artery to put an A line in, or how we intubate and make sure we don't put in the esophagus instead of the trachea. I mean, there's a set of clinical skills that we use and are trained extensively in, so we're effective and proficient in delivering an outcome.
Mhm.
Contend that compassion is the signal to patients that we really care about them,
Mhm.
and we see them, and we're here for them, and we're attentive to them. All the diagnosis and treatment in the world, in the absence of that experience by patients, is going to leave the clinical intervention short in terms of its overall global impact. And for us to say we want to be a compassionate organization, yet we don't develop our care team members on what are compassionate behaviors specifically that we can do in the
Mhm.
exam room, I think it sets an organization up for failure in regards to building a really compassionate culture. The other thing that I think is interesting, and I want to get your thoughts on it, and you approach this a little bit, is that what does delivering compassion do for those that are providing it? A family medicine physician, a nurse, a specialist, whatever it may be. I am going to recognize a need. I'm going to recognize suffering. I'm going to have a desire to be able to make it better. I want to be able to want this to go away, and I'm ready for action to relieve that suffering. I'm going to deliver compassion. What does that set of actions do for those that are providing that compassion in your
Mhm.
mind?
Yeah, yeah. Well, basically, it fills us. It makes us feel rewarded. It makes us feel that what we're doing is meaningful. And it is really, it is what sustains us. It fills us with a sense of purpose. That's what keeps people doing what we do. Without that feeling that you're doing your right work, that you're moving through the world with this compassionate stance, without sort of the privilege of being able to do that, I think it's just a recipe for, turning away from the field. And as you pointed out, we can't afford to do that. I think there are teachable, learnable skills too. I mean, it is innate, and I think our main job is getting rid of the barriers and the impediments. But there are teachable, learnable skills, to your point. I think we can teach ourselves to pause, to center ourselves before we engage. We can teach ourselves to observe and learn how to correctly interpret nonverbal behavior and cues. We can teach ourselves how to actually listen for verbal cues and clues of suffering. This is so interesting. I've done the research and listened to and read through transcripts of, clinician-patient interactions. And it's amazing to me because we're often fixated on our cognitive ability to render a differential diagnosis. And what we skip over is everything that pertains to things that don't fit into one of our, buckets of what we're considering. So we'll skip over some of the social cues, which actually may be the cause of why the person's in the office in the first place, you know. But that's something that really takes time to sort of embed into practice and to get good at. So picking up on verbal, nonverbal cues, and then eliciting concerns, really understanding what exactly, has your experience been like, and what are you most concerned about? How do you think this disease is functioning in you? How does it work? What have you tried? All of those kinds of questions before you can really come up with a solution, and then try and work with them to see, is this the right solution for you? How does this fit into your belief model and your family circumstances, your social circumstances? Are you going to actually be able to do what we've been talking about? And then, of course, continuous caring follow-up and not losing touch. Being a continuous, caring, compassionate, connected presence, in my mind, is what compassion is all about.
Well, so beautifully said. And I think as we reflect on the importance of compassion at the leadership level, to bring compassion and a desire to relieve suffering and to care and to take action to advance the well-being and the stability and the engagement and the retention and the discretionary effort of the people that we lead. How do we embed compassion at the team level so we can look out for each other, care about each other, hold each other, love each other
Yeah.
in the context of clinical families that work together providing care?
Yep.
How do we bring that same compassion into the exam room?
Yeah.
And I would even contend that most every clinician, nurse, physician, APP that I've ever met, those that are touching patients directly, want to be a deeply caring, compassionate clinician.
Mm-hmm.
They want that for themselves. They aspire that for themselves. And when we live into the purpose that we believe in,
Mm-hmm.
is the source of human contentment.
Yes.
It's like, I am being who I know I should be. I'm doing the things you said, living your right purpose, I think is what you said.
Yeah.
Yeah. And compassion is a substrate for that. I'm going to be compassionate for my teammates as a leader and for the grocery clerk at Vaughn's.
Yeah.
I'm buying my coffee from.
Yeah.
So it's such a transcendent, beautiful human attribute that tends to get displaced and sometimes washed away with the burden that we have layered on our care teams
Yep.
right now.
I
So
agree. I agree.
it's part of it. So anyway, Beth, it's been lovely to have you here. I'm so grateful for your advocacy and your expertise and your voice on international and national and organizational and team levels. The brilliant work you've done with the Schwartz Center for Compassionate Care, your work with the Lorna Breen Heroes Foundation that we both had a chance to work with, and your working hard to raise compassion for care team members and patients and families alike. You're a difference maker and a light in the world.
Oh, thank you. That's very, very kind. And we all need to join in the effort. It takes a village, right?
Yes, for sure. And there's so many comments. There was more questions than we could possibly field. We're gonna try to field some of those in our follow-up, and we'll provide some resources as
Okay.
well. And again, thank you, Beth. And I think the closing note is, let's graft compassion into our way of being and way of living to be a light in the world.
Yes.
And we have 100% dominion over that one. We can be that should we choose.
Oh, yes, yes, yes. We know how to be compassionate. What we have to do is live it and figure out how to get rid of everything that's in our way.
Yes, yes. Well said. And on that, thank you very much. And thank you for joining This Clinical Life. We've got a fabulous next episode coming up that we'll start to promote. And Beth, thank you and have an amazing day. Thank you, everybody, for.
Yeah, thank you for having me, Steve. It's been really a treat.
All right. Thanks. This Clinical Life is out.